Make sure you gap graft for the win. So in a recent video, we were talking about how we do our immediate implants in the aesthetic zone. And one of the comments that we got was, hey, can you talk a little bit more about the concept of gap grafting? And I said, sure. And so that's what we're going to talk about today. So when we're doing immediate implant placements, we're taking a tooth out, we're curetaging and irrigating, getting all the infection out. We're immediately placing an implant with a type 4 fully guided system. And what we have is we have a cylindrical shaped implant in an extraction socket that's typically not cylindrical. Okay. So if it's a central, it's triangular shaped, right? And so that means there's a gap between the implant and the bony housings around it and the avillus. And what we want to do is we want to graft that gap. And the reason we want to graft that gap is because we want to try to hold the buccal plate in place so that it doesn't have too much shrinkage and collapse during the healing process. That's it. We're not actually grafting it with the intent of directly affecting the healing of the implant because the implant is going to heal. What we're attempting to do is maintain the volume of hard and soft tissue so it doesn't collapse as much. And we call that gap grafting. And my favorite bone graft material is Mineraloss, which is a cortical cancellous chips. If you're buying cortical cancellous chips, try to get the smallest ones you can because the gap that you're going into is often very, very tiny. For a central, usually the tooth is about at the neck of the tooth is about 6 millimeters in diameter. And the implant you're placing there is usually about a 4.2, which means you have less than a millimeter on the mesial and distal side of that implant to get your gap graft in, which means the graft particles have to be tiny because if the graft particles are really big, they're not going to get into the gap. In order to accomplish this task effectively, you also need a special instrument, and that is a gap grafting tool. Hugh Freedy has a set that is on their website. It's a gap grafting set, so they have different angulations for different locations in the mouth. And Salvin has one too called the Titanium Curved Pocket Packer. It has two different shapes on either end of the instrument, and you can just flip it over depending on where you're working in the mouth. And what this is it's a condenser that looks like a rather thick spatula, so to speak. And you use the end of the spatula to get down into the very tiny spots to effectively get your gap graft material down as deep as you can go. Now, do you need to go all the way to the bottom? No, you don't. As long as you get the gap graft as far down as you can, that little bit of space towards the apex of the socket, now you're talking less than a millimeter. You're starting to talk like 400 microns of a gap. That's going to fill in with a blood clot and it's going to heal with bone just fine. So this is more towards the coronal region. Now, do you need a barrier membrane? And the answer is no, in the vast preponderance of cases. So let me be very clear about this. If I'm doing an anterior case, the vast preponderance of those cases get an immediate provisional non-functional crown. And we usually make that ahead of time so that it's ready to go. With the guided system, we're so accurate with our placement that we just screw in the crown when we're done, right? With very little adjustments. But what that does is it does what we call the socket sealing technique. It literally acts like a cork in a wine bottle. It goes in and it seals around your gap graft with the tooth. And if you've watched any of our videos on the channel, you go, that's what it looks like 10 minutes later. And it looks like a natural tooth and you can hardly tell which tooth has been extracted and replaced because you're literally packing in the graft material and corking it into place, so to speak, by using your provisional crown. In the posterior, all I use is stock abutments, regular stock abutments. And because there's no blood supply, the gap graft is going to be fine exposed to the occlusal table, okay? You don't have to try to get a barrier membrane in there, okay? So you're doing a molar, you take the tooth out, you place the implant with a guide, you gap graft, but you didn't flap anything and the bone's all intact all around, just leave it alone. It'll heal beautifully. Now make sure you don't do this. Everybody wants to build the graft all the way up to the top of the tissue level, and that's a mistake, okay? Because there's no blood supply to maintain that graft, and so those particles on the top are going to slough off in the first couple of days, and you'll get a phone call from your patient, and they'll say, doc, I've got these pieces of white material in my mouth. What's going on? And then you've got to manage your patient's expectations. So what you want to do is you want to stop about at the about 1 to 2 millimeters below the surface of where your surrounding soft tissue is, so that that's going to heal a little bit below your soft tissue. So once that clot turns over and it has re-anastomosis, then your soft tissue can crawl right across the top, close around your abutment, and have a beautiful outcome. So that's how we do it in the posterior. That's how we do it in the anterior. It's what we do on almost every one of our immediate cases. In fact, I can't remember a case where we didn't gap graft with an immediate. It's just a very, very solid practice. If you like this video, give us a like, share, and subscribe. Also, if you haven't been to one of our courses, come see what you've been missing at Stanley Institute.